Hello again. Today I will be sharing with you part 3 of our IBS sessions delivered by Dr. Neville Azzopardi. Today's session will be all about investigations and differential diagnosis. Thank you for watching.
So, hello again, and today we'll continue talking a bit more about IBS. Today we'll talk mainly about investigations and specifically on the management of this condition. So investigations. IBS is a diagnosis which can be made based simply on history and examination. Most patients with typical symptoms and with normal examination don't merit further investigations, and the first step should be to recommend lifestyle changes, which we'll get into shortly, and possibly pharmacological therapy. Only if the patient does not respond or if the patient insists, would you consider investigations. And first-line investigations should always be non-invasive. I very, very rarely recommend colonoscopy in these patients unless there is something which is of concern. A number of reasons. Number one, doing a colonoscopy under sedation in these patients tends to be extremely uncomfortable. Number two, it means putting the patient through an invasive test, which very frequently they don't need and which will not help. So non-invasive investigations, blood tests, blood count to exclude anemia, particularly in men, because that would worry us a bit more. Celiac test, celiac screen and thyroid function tests are important. C-reactive protein might help. The problem with the blood test, blood inflammatory markers like CRP and DSR is that they are non-specific. So you can have a high CRP in a patient with IBS, and you can have a normal CRP in somebody who has got inflammatory bowel disease. So it's not a test I particularly like, but we do recommend it. Liver and renal profile, but the most important test is probably the stool test, the fecal calprotectin. If you're suspecting, obviously, infections, if a patient has chronic diarrhea, you may want to do stool studies for CNS, OCP, and C. diff. But the fecal calprotectin test is a test which helps me either reassure the patient or else tell them, listen, it's better if we do the colonoscopy. The fecal calprotectin is an inflammatory marker which can be measured, and it tells us a low level basically means that there is no inflammation in the gut. So if the symptoms are very florid, then the symptoms are coming from IBS. If the fecal calprotectin is high, that might indicate that there might be an underlying inflammatory condition, which might be anything from an infection to inflammatory bowel disease and possibly even malignancy. So the fecal calprotectin is usually the marker that I use to decide whether a patient with typical IBS symptoms merits a colonoscopy or not. Low level, less than 50, it's IBS. Anything above 50, you need to consider an endoscopy. Frequently we get borderline tests, anything between 50 and 150. If the history is typical of IBS, here I might consider repeating a second fecal calprotectin test before recommending the endoscopy. But then depends on how anxious the patient is, on what the patient wants to do. I always offer the colonoscopy in these cases. So when to go for an endoscopy? If there's a positive fecal calprotectin, as we said, if there's a family history of colonic tumors, even if the patient is relatively young, we've seen patients with young patients with colorectal cancer, or if the patient is above the age of 50, and here you do it once again to screen for cancer and also to screen for polyps. As you will see, as you can see from this chart, food intolerance tests do not come into the investigation of IBS. Like all other gastroenterologists, like most gastroenterologists in the world, we don't recommend food intolerance tests. I don't think it's a test which helps much, and really the results of the food intolerance tests in most cases mirror the FODMAP diet, which is much cheaper to do and usually gives better results than diets based on the food intolerance tests. But that's as an aside, it's available locally. Some patients opt to do it. There are doctors who recommend it. But as I said, it's not something that is actually recommended in the investigation of IBS, and it's not something that I personally do. What are the possible differential diagnoses? We've mentioned celiac and thyroid problems, diverticular disease. inflammatory bowel disease, malignancy, infections. And finally, I'll talk briefly about lactose intolerance, SIBO, and pelvic inflammatory diseases. Lactose intolerance is extremely common, and I can tell you that most, if not all, patients with irritable bowel syndrome are lactose intolerant. Once a patient presents with symptoms of IBS, simply tell them to get rid of the lactose from their diet, and nearly all patients will improve or will get some improvement. So the question is the patient just lactose intolerant, or is it just IBS? Patients who are just lactose intolerant will improve simply by avoiding lactose. Obviously, patients with IBS need to follow the FODMAP diet, as we shall see. So it's not just avoiding the lactose, but lactose avoidance is part of the FODMAP diet, as we shall see. SIBO refers to small intestinal bacterial overgrowth. This is a terminology which has come afore in the last few years, and basically it describes the growth of certain bacteria in the small intestine, typically after surgeries, after the use of antibiotics, after certain infections. Not easy to treat. I don't think we have the test to check for SIBO locally, but it can be tested. I've had patients who did the test. The problem is that the results are frequently borderline, and most patients who believe that they have SIBO because they spend a long time reading on the internet will actually have IBS. But if you have a patient with SIBO, you might consider using antibiotics like metronidazole or rifaximin. I've had many patients who are basically convinced that they had SIBO. I gave them the antibiotics and they did not improve. And in the end, there was some relief by targeting the symptoms for the IBS that they were actually. Finally, gynae problems, you have to consider these in women, particularly if you have high inflammatory markers, the typical symptoms related to menstruation and to ovulation. So in these patients, you need to consider referral to the gynae. Finally, this is a talk which has been sponsored by Energast. A few words about it, though Rachel will be talking in more depth on this new drug. It consists of sodium butyrate. It has a number of uses. It's not just used in IBS. It's also used in diverticular disease. It's also used in patients with chronic diarrhea or traveler's diarrhea. And what it does is it replenishes the levels of sodium butyrate in the gut. And this is a compound which is essential for healthy functioning of the gut. And we know that in IBS, the levels of sodium butyrate tend to be low. It's a longish course of treatment, usually a number of months, but I've had a lot of patients who did improve with this drug. And being a very safe drug with no side effects, a bit like probiotics, I tend to use it first line before I consider other drugs which might have a bit more side effects. But I'll leave you to Rachel to explain a bit more about this drug and about how to prescribe it. Thank you.
Thank you, Dr. Neville Azzopardi. A few brief notes regarding Energast. In IBS patients taking Energast, there was a statistically significant decrease in frequency of abdominal pain. This is a clinical study of a duration of 12 weeks. And as you can see in the bar graphs, there was a decrease, 60% decrease in spontaneous abdominal pain. There was a reduction, a 52% reduction in postprandial abdominal pain, and a 57% reduction of abdominal pain during defecation. Thank you for your attention.